Hi, thank you for watching my YouTube channel. I'm Dr. Hassan Barani at the Barani Eye and Retina Center. I just wanted to share with you this complex cataract surgery in a patient who is has mental retardation and has a dropped lens in the other eye, with this eye having pseudoexfoliation, zonulopathy. So I prepared the patient and explained to them that this patient may need vitrectomy, may need Yamani. So in this, you notice that I already planned for Yamani just in case we would need to kind of change our plan. So here I'm doing the centration and for the Yamani. So this patient has severe pseudoexfoliation, mature cataract, let's say about, a 5+ maybe. And here I'm removing the pterygium, so I have the exact measurement for the Yamani. This way I'm already set up to perform the Yamani, so always have a plan. B and C in place. Even I usually have the IOLs already ready. So I have the SA60AT, the Alcon monofocal lens. I have the 3-piece. I have actually two kinds of 3-pieces lens, the Alcon 3-piece, and one is called the Equisense. This way I just need to call my assistant and tell them what I want, and so I don't have to worry about getting things ready. Here I'm using preservative-free adrenaline, AC viscoelastic. Seems like a stable lens. However, when I'm doing the capsulotomy, which went actually quite well, see, that kind of rocked right there. If you notice, it rocked. So here I completed the capsulotomy. Then I'm doing the hydrodissection. And here it went very nice. It's rotating nicely. So up until now, we're actually doing very well, nicely. And what happens is that actually the thing is intra-op usually, while I'm removing the nucleus, you'll start noticing the capsule doing some shady things. So here I don't have a capsular tension ring, and here I'm doing the sculpting. I'd like to do the divide and conquer even in complex cataract surgeries, which is actually works just as fine as chop. But I do adjust here. I broke the posterior. There's still some remnant adhesion. Here I did a little bit of stop and chop. It's not coming. Okay, here. And finally I got one piece. So what I did, I got at least one piece. That one piece allowed me to move the lens freely, or at least easier way. Next, I'm trying to get that, and it's, I think I failed trying to get that in position. I'm using copious amount of viscoelastic. I'm rotating the lens, so just taking your time. That's the thing. Don't rush. I stopped. I put some viscoelastic. I rotated it with the viscoelastic cannula. I didn't have to continue rocking the lens unnecessary. Anyway, so here I divided this piece, and then I'm trying to get that piece into positioning into the iris plane, and it's not coming. And then here we start noticing that the capsule, can you slow it down? Can you slow one? No. So see here, I got that piece. I'm trying to tell my assistant that the capsule started coming into the center. So from temporally nasally. So the temporal capsule started moving, and what happened is that I got a vitreous wick. If you notice, there was a vitreous wick that came and was preventing me from eating this lens. Anyway, so here we're continuing. So a vitreous wick came through the zonulopathy temporally. There it is. So I kicked. See here, I put viscoelastic to reshape the bag. I stopped here, and then I planned for CTR. So I think that was the best decision. Notice how I loaded the CTR in the other way, because I wanted the CTR to go towards the area of zonulopathy, not the opposite of zonulopathy. So I made sure I'm in the bag. Of course, that was pretty scary just doing that. Here I got all the way, and with the help of the Sinski, I got it. And now I can tell that the bag is more stable, and I was able to see I was easily able to remove the remaining of the nucleus and the cataract. See, there was a vitreous wick I removed with the Sinski. Anyways, because that was bothering me, so I didn't have to use a vitrector. Just sometimes in Sinski by itself can help. I'm finishing up removing the lens matter. Of course, this is, even though we did not have a posterior rupture or posterior capsule tear, it's still advisable to implant a 3-piece IOL in these kind of lens, even in cases that you don't have posterior capsule rupture. So in this severe pseudoexfoliation with the CTR, I opted to put a 3-piece lens. So here I'm removing whatever necessary. You just have to be really care not to, because most of the complications in pseudoexfoliations happen during IA, in my opinion. That's when you kind of get the bag, you eat the bag, and the bag just tears apart. So here I'm putting a 3.2 millimeter keratome to implant the MA60 AC lens. A60 AC lens, which is a 3-piece by Alcon. This lens is, just the haptic kind of drives me crazy sometimes, because this haptic is pretty easy, friable, can hurt the haptic. So here I'm trying to use the Sinski, didn't work. Tried here. So what I did is I put the haptic inside in the sulcus using this rated retina forceps, and that kind of worked. I was trying to dial it in, but I couldn't find the other haptic. Anyway, so here I using the Sinski, the lens in the bag looks good, and I decided to do a PI, which I do something routinely to control IOP and just keep patients like this in a stable manner. I think anterior chamber PIs helps tremendously with IOP control, with IOL stability, with AC stability. I'm cauterizing the PI to make it round. So this pupil is not so greatly round because of the PI. Here, washing the AC, make sure that there's no remnant of the viscoelastic. Notice my paracentesis should not go over the pterygium, otherwise it won't close. It won't So everything looks cool. There's no leak. We put intracameral cefuroxime as an prophylactic antibiotic, and this patient, actually there was a leak. I thought there was no leak apparently. So this patient is a mentally retarded patient. So in that case, I just wanted to make sure I'm securing the wound carefully, making sure that he's not leaking and there's no risk of endophthalmitis. I use usually the 8-figure technique to close the wounds. I don't like the single stitch for these kind of cases. So anyways, this patient did very well, and this was quite successful for this patient. I'm sure he's going to be really happy with the results. So anyways, thank you very much for following my channel, and please do subscribe and like, and see my other videos. Thank you.